Trap money, Benny. This shit got me in my feelings.
Neuro high yield. So first we're going to talk about stroke. There is ischemic stroke, hemorrhagic stroke, and TIA. Why is stroke important? Because it's one of the top 3 causes of death after MI, cancer, and then stroke, which is number 3. So basically, the 2 greatest risk factors for stroke is something you should definitely remember because the steps love to ask about risk factors. So the 2 greatest risk factors for stroke are age and hypertension. You should know the difference between ischemic, hemorrhagic, and TIA. A TIA is basically a stroke that lasts for less than 24 hours and symptoms resolve within 24 hours. And this is reversible because there is no actual infarction of the brain cells. It's basically when the clot resolves or if there's like a collateral circulation that perfuses that part of the brain enough to save it in time. So the key sign for the board exams for a TIA is usually someone will have something called amaurosis fugax, which is when you have a cholesterol plaque that embolizes to the ophthalmic artery and you get a curtain-like blindness that happens transiently and goes away. This is a type of a TIA. A TIA is a stroke that resolves within 24 hours. You should also know how to work up a stroke. What is the first step? The first step is to do a head CT without contrast. It's one of the only times during medicine, or at least for the purposes of the shelf and board exams, where you'll do a CT without contrast. What is the other time you do a CT without contrast? It's the other big one is for kidney stones. Why do you do it without contrast? Is because contrast is white and blood in the brain is also white, so you don't want to camouflage the contrast with the blood. So you do a head CT without contrast, and this is not to diagnose a stroke. This is to rule out hemorrhage. Why? Because what is the main treatment for ischemic stroke is TPA. TPA, it dissolves the clot, but it also increases your risk of bleeding. So when you do a head CT, it's just to ask yourself, is this hemorrhagic or not? Because if it's not hemorrhagic, then you're going to proceed with TPA. That's why you do a head CT without contrast. And remember that 85% are ischemic and the other 15% are hemorrhagic strokes. The most common place where you'll find a stroke is the MCA. You're going to have to remember the homunculus, which is basically that the middle parts of the brain along the sagittal suture control your lower extremities, and the outer parts will control your upper extremities. So if you have ischemia on the outer parts of the brain, then you're going to have more symptoms of upper limb paralysis and weakness and sensory loss. Whereas if it's the lower limb, then that will be pointing more towards the middle parts of the brain along the sinus. And you should know the main arteries that supply this, because sometimes they'll like to ask what artery is being affected. So if it's along the middle, then that's the ACA. If it's along the sides, then that's the MCA. Also remember that the left MCA also supplies the language areas of the brain. So you have Broca's area and you have Wernicke's area, right? So Broca's area, they like to ask us what part of the brain is Broca's area in, and a lot of people will say temporal, but it's not. It's actually the left frontal, the left inferior frontal lobe, to be more specific. Wernicke's area is in the temporal lobe. So that's why when people get left MCA strokes where it controls your language, that's why they have a lot of difficulty speaking. If it's more anterior, then you'll have Broca's aphasia, which will be expressive aphasia. So they can understand what you're saying, but they won't be able to put it into words. Whereas Wernicke's aphasia is more, they are just saying word salad. So they don't understand what you're saying at all, and they'll speak words that are real words, but there's no meaning whatsoever. So a classic left MCA stroke will present as some sort of language deficit. If it's on the MCA, that will be the upper extremities based on the homunculus. So right arm weakness and sensory loss. And also remember that since this is coming from the higher parts of the brain, this is an upper motor neuron deficit, so you'll also find hyperreflexia. With a hemorrhagic stroke, usually happens from the three big ones are trauma, ruptured Barré aneurysm, and the arterial venous malformation. A subarachnoid hemorrhage will be classically the worst headache of someone's life, right? And then they'll have symptoms of intracranial pressure. So they might have papilla edema, they might have nausea and projectile vomiting, and headache. So if someone has symptoms of a stroke with headache and nausea and vomiting, you should think of increased ICP, which points towards a hemorrhagic stroke. Same thing, you'll do a head CT without contrast and it'll show blood in there. If it's caused by a Barré aneurysm, this is also associated classically with autosomal dominant polycystic kidney disease, right? So they have kidney disease as well, and then you're going to treat it with surgical clipping. If the subarachnoid hemorrhage is unclear on a CT, what is the next best step? You should do lumbar puncture. The lumbar puncture will show red blood cells in it, and that's called xanthochromia. Whenever you diagnose a stroke, remember that you should always do afterwards a workup for the source of the stroke. So the big three workups are a carotid Doppler, right? An echo and an EKG, because you want to check to see if there's any carotid stenosis, right? Carotid stenosis caused by atherosclerosis of the carotid arteries, which predisposes to thrombosis. The second one is an echo because you want to check to see if there's any wall motion abnormalities, and that can predispose to a thrombus, which would lead to an embolus. Why? Because if your heart isn't contracting well, there's areas inside the heart chamber that aren't flowing well, which is what we call stasis. If there's stasis, this promotes hypercoagulable state per Virchow's triad of hypercoagulability, right? Endothelial damage, stasis, and hypercoagulable state. And then the last thing is an EKG. Why do you do an EKG? Because a lot of the times too, people who have AFib, which you'll see on an EKG, right? Irregular RR intervals with no clear P waves. These people, the same principle. The atrium is not contracting well, and when this doesn't happen, then you're more prone to making a thrombus. And that's why with people with AFib, give them a CHAD-VAS score, right? If it's greater than 2, then you're gonna give them warfarin. That's because they have a high risk of developing a thrombus, which could lead to a stroke. So you gotta anticoagulate them. If it's less than 2, then it's aspirin, right? So CHAD-VAS score. CHF, hypertension, age. If it's greater than 72, that's 2 points. Diabetes, stroke, previous stroke, that's another 2 points. Vascular disease, so that's like peripheral artery disease, coronary artery disease. Age, the second time, which is 65 plus, that's 1 point. And sex category, if it's a female, then that's 1 point. Next is a lacunar stroke is in the deep subcortical parts of the brain. It'll be the basal ganglia, the internal capsule, or the thalamus. And this is most often caused by hypertension. So hypertension will cause arteriolosclerosis. There will be thickening of the wall of the arteries, which causes narrowing and poor perfusion to the deep parts of the brain. When this happens over time and it heals, you get these things called lacunes. They're almost like deep little like hollow little cavities in the distal most parts of your lenticulostriate arteries. Basically, when those lacunes form, you can get something called lacunar stroke. So the two most important ones to know are something called a pure motor stroke and a pure sensory stroke. So a pure sensory stroke is based on infarction of the thalamus, specifically the VPL. So if someone has a stroke and they only have sensory deficits, this is a lacunar stroke at the thalamus. If they have something called pure motor stroke, this will be at the internal capsule, because if you remember, the internal capsule is where you have the motor neurons that are converging, controlling the upper and lower bodies. So the motor neurons that start at the cortex from the outside and the inside, they start separately, but they start to join at the internal capsule. So if you have an infarct there, you have infarction of fibers from the middle and the outside. So you would predict that the person who has a stroke at the internal capsule will have upper extremity and lower extremity paralysis. So complete hemiparesis. This is called a pure motor stroke. If it's a pure motor stroke including upper and lower extremity, then you know that this is a lacunar stroke and you can localize it to the internal capsule. So if someone has a stroke that's just upper extremity or lower extremity, then that's not the internal capsule. That's coming from more cortical areas. If it's both up and down, then it has to be lower down where the fibers converge. Okay, so for some reason they always like to ask you this, but remember the left hemisphere is what controls your language, which causes aphasia. The right parietal hemisphere is which we call the non-dominant side. It's the part that causes hemi-neglect. So if someone is completely ignoring one side of their universe, then you can safely guess that this will be on the right parietal lobe. Also, if someone has signs of increased intracranial pressure, remember I said the main signs are papilledema, projectile vomiting, headache, nausea. How do you lower ICP? You should know the big three treatments. 1, hyperventilation. 2, mannitol. And 3, raising the head of the bed. Mannitol is, if you remember, it's an osmotic diuretic. It's highly concentrated and has a lot of oncotic pressure. This will pull fluid out of the cells in the brain into the vasculature, which will be urinated out. The second is hyperventilation. Why does hyperventilation decrease ICP? So remember the metabolites, there's like CO2, hydrogen, lactate, all these things. If the tissue has a lot of this, then you get vasodilation because you want to wash that out. The arteries will expand to wash it out. If someone's hyperventilating a lot, the tissues become low of CO2. What the arteries will do is vasoconstrict for a bit to make the tissues hypoxic, and then that will increase the metabolites in the cells, which is a way for it to like regulate the CO2 in the tissues. And then last is elevating the head of the bed, which increases venous return. Also, treatment of stroke. If it's within 3 hours, what do you do? TPA. If it's outside of the 3-hour window, outside of strokes, what's the best you can do? This is for ischemic strokes. Aspirin. This is high yield too. If someone has carotid stenosis and they're symptomatic and the stenosis is greater than 70%, that is if you've had syncope or like TIAs, then what should you do? You should do something called a carotid endarterectomy. If it's below that and you have carotid stenosis less than 70% occlusion, what's the mainstay treatment? Aspirin. Hypertensive emergency first-line medications, what are the 3? 1, nitroprusside. 2, labetalol. 3, hydralazine. To diagnose Tourette syndrome, you need a motor and a phonic tic for at least 1 year. A phonic tic meaning anything that makes a sound. If you're like clearing your throat or like making noises, that's considered a phonic tic. And a motor tic is like head twitching, moving, at least for 1 year. That's how you diagnose Tourette's. How do you treat it? Clonidine. Essential tremor is also known as familial intention tremor. This is a tremor that's worsened with movement. Like if you're holding a cup, you can't hold it. You'll start shaking and you can't put it to your mouth. That's worsened with movement. It's better at rest. It usually has a family history and the symptoms will go away with drinking alcohol. How do you treat it? Beta blocker. Then there's Friedreich's ataxia. I think of Friedreich's ataxia as the triad of scoliosis, hokum, and dorsal column problems. And then remember, it's one of the trinucleotide repeat disorders, so it's Friedreich's ataxia, GAA. There's dorsal column problems, so they'll have decreased pressure, proprioception, vibration, and touch, and they'll have the scoliosis, and I always remember this one, it's high yields, it's always associated with a HOCM. Hypertrophic obstructive cardiomyopathy, remember that's where you get the interventricular septum that's thickened, and it happens when young people who play sports have sudden cardiac death because there's poor outflow to the perfusion to the brain, which can cause syncope, and it's also predisposes to rhythm. Delirium usually happens in an elderly person. The most common causes are infection or polypharmacy, meaning they're taking too many medications. Notorious for causing delirium in the elderly are benzodiazepines and antimuscarinic medications like Benadryl, right? Or like, first generation antihistamines. Anything with the antimuscarinic properties will predispose the elderly to delirium. In a question of delirium, you'll see an elderly patient who has like a UTI or taking benzodiazepines or Benadryl, and they have something we call waxing and waning consciousness. So they'll have periods of sleepiness, and then they'll be agitated, and then they'll be sleepy, and then they'll be agitated. And then there's something called sundowning, which is they get worse at night. So they're fluctuating in their consciousness. How do you treat it? When they're agitated, you would treat delirium first line with haloperidol. Different from dementia such as Alzheimer's, because Alzheimer's they're constantly out of it, whereas delirium, it's fluctuating. That's the key point. Multiple sclerosis, the key thing you want to tell yourself is it's spread out through space and time. First, you have to know that it's an autoimmune condition that affects the upper motor neurons. So any upper motor neuron, it's spread through space and time. So space meaning it can affect any upper motor neuron throughout the whole body. 1 second you might have left spastic paralysis, and then it'll go away, and then you'll have right leg spastic paralysis, and then it'll go away, and then you'll have urinary incontinence, and then it'll go away, and then you'll have blindness for a few weeks, and then it'll go away as well. So that's what I mean by spread through space and time. Space all over the body, and time meaning it comes and goes. So in a vignette, look for a patient. Usually the stereotype is a young female in her 20s, Caucasian, like 25-year-old white female who will have a history of blindness that occurred a year ago, and then it just went away. And now she's back because she's having like spastic paralysis in her left arm and incontinence. This is a textbook definition for multiple sclerosis. And how do you diagnose it? You want to do an MRI, and you'll have periventricular plaques. Also, a lumbar puncture will show oligoclonal bands, which is like IgG antibodies that are specific for multiple sclerosis. You need to know the two treatments. The disease-modifying one is interferon, and for an acute flare, you want to treat with steroids. And then there's Guillain-Barré, which is a peripheral nervous system autoimmune disease. So remember, multiple sclerosis is central, and then Guillain-Barré is peripheral, but this also affects the neurons. This one is classically a patient who had an upper respiratory tract infection or severe infectious diarrhea, usually Campylobacter. A few weeks later, they'll start getting ascending paralysis. Remember, this is weakness more than sensory loss. The main complaint is weakness that ascends from the toes symmetrically. This is Guillain-Barré. How do you treat it? With IVIG. And if that doesn't work, then you want to do plasmapheresis. Then you have myasthenia gravis. Myasthenia gravis is when you have the autoimmune as well, where you have the antibodies attacking the neuromuscular junction. This will be a vignette where it'll be like a young librarian. I don't know why, but it's always like a librarian or something like that. Also female, and she'll be having ptosis, weakness of her head, problems swallowing. She'll be having weakness that gets worse through the day. This is the key. It gets worse throughout the day. This is myasthenia gravis. Remember though, this is muscle like at the junction, so her reflexes will be normal. Her deep tendon reflexes will be normal. How do you diagnose it? There's a thing called the edrophonium test, which is an acetylcholinesterase inhibitor, which increases acetylcholine at the neuromuscular junction to have quick relief of symptoms. How do you treat it? You treat it with pyridostigmine, which is also another acetylcholinesterase inhibitor. And then they always like to ask this, but what kind of imaging should you do after you diagnose it? You should do a CT of the thorax. Why? Because myasthenia gravis is often associated with something called a thymoma, which produces those autoimmune antibodies. If you find they might even show you a CT where if you look around at the thymus, so just posterior to the sternum, you might see a mass. Anterior to the heart, posterior to the sternum. And then there's Duchenne and Becular muscular dystrophy. This one's pretty simple. It's the kid who shows the Gower's sign, which is where they can't get up on their own. They'll have to push off with their hands and then use their hands to push themselves off their legs, like they're gonna be climbing up their legs with their arms to help extend their back. In Duchenne, this happens at like age 5, whereas Becker is more like 18 to 20-year-olds. It's X-linked recessive, and remember, this is where you have the dystrophin, missing dystrophin. And then there's tuberous sclerosis, which is the mnemonic people use as ash leaf spots, shagreen patches, heart rhabdomyosarcomas, L I can't remember, epilepsy, angiomyolipoma of the kidneys, and facial fibromas. Then there's Sturge-Weber syndrome, which is when you have the port-wine stains on the face with retardation. This is Sturge-Weber. And then there's von Hippel-Lindau disease, which is the triad of renal cell carcinoma, pheochromocytoma, and cavernous hemangiomas of the brain. Then there's Arnold-Chiari formation, which is where you have the triad of myelomeningocele, syrinx, and tonsillar herniation. Remember the syrinx? That's when you have, in the central canal that runs up and down the spinal cord. It is like a pocket pool of CSF, but this kind of stretches out and puts pressure on some of the neurons in the spinal cord, particularly your spinal thalamic tract. And this is where you'll get the loss of pain and temperature along the arms bilaterally, the cape-like distribution. That's a syrinx, and it usually happens in the cervical region of the spinal cord. Then there's a Brown Séquard. A Brown Séquard is usually caused by a stab wound that hits the side of the spinal cord. So like you just get transection of one half of the spinal cord. So the key here is understanding how the 3 big tracts of the spinal cord work. You have your cortical, you have your dorsal column tract, your spinal thalamic tract, and your corticospinal tract. The corticospinal tract is the descending motor tract. The spinal thalamic tract is ascending, it senses pain and temperature, and your dorsal column tract senses pressure, proprioception, vibration, and touch, and that's also ascending. So I'll review the tracts in a bit, but remember that the symptoms here are ipsilateral paralysis, right? Ipsilateral loss of pressure, proprioception, vibration, and touch, and contralateral pain and temperature because of the 3 pathways. So let's review the 3 pathways in order to understand this. So first, your corticospinal tract is what controls motor control of your body. And so it starts in the cortex of the brain, it travels down through the internal capsule, and then it decussates at the pyramids, which is like right around the medulla, and it crosses to the other side. And then it travels down the spinal cord, and then finally, wherever it's destined to be, whatever muscle it's destined to control, it'll finally synapse one more time at the lamina 9, which is like, in your horns, it's at the anterior horn. right there, it'll synapse one more time, and that will be the lower motor neuron. So the corticospinal tract has two neurons. And then you have your dorsal column tract. The first motor neuron will come into the spinal cord and travel up the dorsal column of the spine. I don't know if this matters anymore, but if you're curious, it's what we call the fasciculus gracilis and the fasciculus cuneatus, right? The gracilis is for lower extremities and cuneatus is for upper extremities. But for our purposes, just think dorsal column. It'll travel up the dorsal column, then it'll synapse at the nucleus cuneatus around the medulla level. It'll cross, and then it'll go up to the thalamus where the VPL is, and then it'll synapse one more time, and that will go to the cortex. So that's a 3-neuron tract. And then the last one is the spinal thalamic, which will come feed into the spinal cord through the posterior horns. It'll synapse once, and then it'll cross at that level. See how the other ones, they cross higher up? This one will cross in the spine wherever it comes in. It'll come up through the contralateral side, and then it'll synapse one more time in the VPL, and then that'll go to the cortex. If that doesn't make sense, just remember the only one that's contralateral is pain and temperature. Say if you get a stab wound to the right and it results in a brown saccade, you will have loss of touch on the right, loss of movement on the right, but you'll have loss of pain and temperature on the left. Polio is basically just damage to the anterior horn cells. That's where, remember, the corticospinal tract synapses. This will actually only affect the nuclei of the lower motor neuron and beyond. And so it's important to know the difference between a lower motor neuron injury and upper motor neuron and how that presents. A lower motor neuron injury will have fasciculations and flaccid paralysis. So it's just completely limp. An upper motor neuron injury will have spastic paralysis, so it's very stiff, and hyperreflexia. So let's integrate this. A person with multiple sclerosis would have upper motor neuron symptoms, hyperreflexia and spastic paralysis. But someone with Guillain-Barré will have hyporeflexia and flaccid paralysis. Same with someone with polio. And then there's something called Lou Gehrig's disease, which is ALS, amyotrophic lateral sclerosis, which is a combination of upper and lower motor neuron deficits. So if you get a vignette where someone has physical exam findings that are very confusing, like they might have flaccid paralysis but hyperreflexia, and it doesn't make sense, you should think of Lou Gehrig. Benign paroxysmal positional vertigo, BPPV. This will be a patient who says that when they lie down or get up or move their head suddenly, they start feeling like a room spinning sensation and they start feeling really nauseous. It's positionally dependent, and you treat it with meclizine. Diagnosis, you could do Dix-Hallpike test, which is where you lay them down and turn their head and look for nystagmus. And then you have Meniere's disease, which is the triad of tinnitus, vertigo, and hearing loss. Meniere's disease is a problem with the pressure in your endolymph. Then there's acute labyrinthitis, which is more low yields, but if someone had a viral infection that preceded hearing loss, then it's acute labyrinthitis. And then syncope. Syncope is really huge for this, and you should think of like the main systems that are involved. And the main ones are vasovagal syncope, orthostatic hypotension, aortic stenosis, seizures, and arrhythmia. So the key to being able to diagnose what type of syncope they're having is in the history. So if someone is having syncope that is caused by arrhythmia, the key here is that it's an older person who fainted out of nowhere. They might have been sitting and then they just fainted. And then when they woke up, they're fine. So the key here too is that any sort of syncope that isn't related to seizures, they will not have a post-ictal state. So when they wake up again, they will not be confused. A person with a seizure will wake up confused. A seizure patient will also have urinary incontinence, tongue biting, and convulsions, and when they wake up, there's a post-ictal state. They'll wake up wet, whereas cardiogenic causes of seizure will not have this. So the main ones are arrhythmia and obstruction or neurocardiovascular. So a person with vasovagal syncope will have a prodrome. They'll start feeling not well right before they faint. They'll have like diaphoresis, they'll have like a headache, they will generally feel not well. They're usually someone who has been standing for a long time or is experiencing some sort of emotional stressor prior to the syncope. And then they'll faint, and then when they wake up, they will have no postictal confusion. So vasovagal syncope is the most common cause, and it's caused by when you have increased sympathetic tone or increased blood pressure that will perfuse your carotid sinuses, but for some reason in vasovagal syncope, this reflex doesn't work well, and the vagal response to the increased pressure in your carotid sinus is too strong. So you get a strong sympathetic tone followed by a strong parasympathetic tone. So then this emotional stressor which causes tachycardia and hypertension is quickly followed by bradycardia and hypotension, and then you faint. There's orthostatic hypotension, which is the key, is this person will usually be volume depleted, right? So they would have been dehydrated or vomiting or having diarrhea, and when they suddenly stand up, the venous return is really slow and poor to come back, and then they won't perfuse their brain and they'll faint. That's orthostatic hypotension. And then the last one is an obstruction. The main one that's important to know is aortic stenosis. So in aortic stenosis, this person will have syncope with exertion. That's the key. How do you tell the difference between a complex partial seizure and an absence seizure? The key here is postictal state. So someone who has an absence seizure will not have a postictal state, whereas someone who has a partial complex seizure will have a postictal state. Because both of the times they might have the lip smacking and staring out into space, so it's confusing. But if the person has lip smacking and then they come back into it and they're not confused, that's an absence. But if they do the lip smacking, staring to the space, and then they come back and then they're confused, this is a partial complex seizure. And then you treat them differently, but it's high yield to know that with the absence seizure, the first line treatment is ethosuximide. Lastly, it's important to know the difference between Lewy body dementia and Alzheimer's. And the key here is in vignettes, a lot of the times they'll have an elderly person who has declining memory loss, but they also will have hallucinations. So you'll have a hard time telling whether or not this is Lewy body dementia or Alzheimer's. And the trick here is order matters. If they have memory loss and then hallucinations, this is Alzheimer's. If they have hallucinations, then memory loss, this is Lewy body dementia. Remember too, Lewy body dementia can also be confused with Parkinson's because they both have Lewy bodies. A Lewy body dementia will have hallucinations first, and it will be followed by Parkinsonian symptoms. And then Parkinson's disease is where you diagnose it. I'm sure you've seen it a bunch of times now, but just for a quick refresher, this will be the slow, shuffling gait with the pill rolling tremor and the doll-like faces. This is classic for Parkinson's disease. Then you need to know how to treat them. Parkinson's disease, the first line is carbidopa levodopa. Alzheimer's is treated with acetylcholinesterase inhibitors. And the main drugs are galantamine, donepezil, and rivastigmine. And then there's that mnemonic called Grandma Doesn't Remember. And then I add a little thing to the end. Grandma doesn't remember me, man. So, me, man, team. And then the last one is tic douloureux. Tic douloureux is also known as trigeminal neuralgia. And in trigeminal neuralgia, it's like one of the worst pains ever. When they're like brushing their teeth or chewing, they'll feel electricity feeling. Most of the time it's V3 dermatome. And like even like wind will cause this intense pain along the dermatome. And you treat that with carbamazepine, which is a sodium channel blocker. Tabes dorsalis is just damage to the dorsal columns, which is pressure, proprioception, vibration, and touch. And this is usually secondary to syphilis. It's the tertiary syphilis, right? Remember how in syphilis you have the painless chancre, the first part. The second part is the rash with the condyloma lata. And then the third part is neurosyphilis, which is tabes dorsalis, syphilic aortitis, and gammas. You treat that with penicillin. And then there's subacute combined degeneration, which is secondary to B12 deficiency. So you see a macrocytic anemia, right? Megaloblastic anemia, so the neutrophils will have extra lobes, and then the B12 levels will be really low, and they'll have dorsal column problems as well as corticospinal tract problems. So they'll have upper motor neuron injuries. That is basically it. I hope you enjoyed this chapter. We'll see you in the next one.
Trap money, penny. This shit got me in my